to deliver to you, ladies and gentlemen. And this topic is the topic that most of us have been waiting for too, because it is the topic that we'll be talking a lot about the update on the nature of the pharmacogenomics in the UAE, or all the challenges and opportunities. This actually is the country that have that considered to have one of the highest standard in the healthcare system. So that is the reason why all the findings and all the discussion will be very useful and very interesting. So ladies and gentlemen, I like to, before we start the next session, I like to reconfirm once again that all of you are reminded that you have a chance to participate in this beautiful discussion. So please kindly take part in the Q&A box down below, as well as once you finish the session, before you leave, please kindly take part in the survey as well, because we have the pilots of survey section down below as well for all of you to take part, and so for all of us to improve it all together, and that we can learn more from each other to create the future collaboration, beautiful collaborations as well. So ladies and gentlemen, without further ado, I'd like to take this very opportunity to introduce to you the representative from the United Arab Emirates University, Dr. Zaina Al-Mahiri.
Good afternoon. This is Zaina Al-Mahiri from the College of Medicine and Health Sciences, United Arab Emirates University. First, I would like to thank the 9th CFARM meeting organizers for their kind invitation and for giving me this opportunity to be here today. And I will present my talk about pharmacogenomics in the United Arab Emirates, challenges and opportunities. My presentation is divided into 4 parts. First, I will give a brief introduction to the UAE, its location and population, from history into contemporary UAE. Then I will illustrate the massive changes occurred in the country at different sectors, especially health, medical education, and research. Then I will take you on a tour through pharmacogenomic research in UAE, ending up with old and continuing challenges and the potential opportunities. So let's start by introducing UAE. UAE, located in the tricontinental crossroads connecting Africa, Europe, and Asia, is located in the southeasternmost portion of the Arabian Peninsula, which represents an important nexus connecting the 3 continents and theorized to have played a significant role during the dispersal of modern humans, with found evidence of that span back to 125,000 years ago. Accordingly, this region has been influenced by a number of human dispersal waves from a plethora of sources, including the out of Africa historical migrations, the exodus of Neolithic agriculturists from the fertile Crescent and North Africa, and the more recent migrations from Asia and Middle East. So these migrations can justify the findings of recent genomic studies applied on the Arabian Peninsula populations that showed that these indigenous populations exhibit the highest intra-population variance when compared to various geographical regions. As a result, indigenous or local UAE population, or also referred as Emiratis, are described as an admixture population who preferably practice consanguineous marriages with rates approaching 50%. Despite these high levels of consanguinity, this population is still genetically heterogeneous, according to the few phylogenetic studies held in Emiratis. And from the historical review, we move into the contemporary UAE. Contemporary UAE was formed by the union of 7 emirates in 1971, including the most known emirate of Dubai, and the biggest emirate, which has the capital city, Abu Dhabi. The discovery and exportation of oil in the 1960s brought a new era of trade and completely revolutionized the nation. With a booming economy, the UAE was able to fund a period of rapid development, and over the last 50 years, the landscape has become overrun with towering skyscrapers. Indeed, this growth was paralleled with an exponential population growth, resulting from the in-migration of workforces from around the globe attracted by the available economic opportunities. So currently, the UAE population, which is approximately 11 million residents in the UAE, around 10% of them are Emirati citizens, and the majority of the residents are expatriates, with approximately 30% being from South Asia. The rapid economic growth allowed major transformations. I briefly describe here some of these transformations in public health, medical education, and in research. So we'll start with transitions in public health. So in the late 1960s, only 50% of newborn babies survived, and 1 out of each 3 mothers died during childbirth. 50 years later, health outcomes are comparable to developed countries, like the maternal mortality rate decreased into 8 per 100,000 compared to 14 in the United States, and the infant mortality also decreased to 5.6 per 1,000 live births, so compared to 5.8 in the United States. So that was the first transition. But the second transition was, unfortunately, an epidemiological transmission that characterized by decline. Although there was a decline in communicable diseases, there was a deep rise in chronic diseases, such as heart diseases, diabetes, and cancer. And mortality from non-communicable diseases, or these chronic diseases among people 60 years or younger, is amongst the highest in the world. So, for example, we can see here a comparison between the cardiovascular diseases related mortality rates in the UAE, which are almost the double of these rates from Germany, Thailand, United States of America, United Kingdom, and Singapore. So given that starting point, it has been remarkable whatever has been achieved in the UAE's health sector, and governmental efforts actually focused until now into introducing private health insurance and encouraging growth of private health provision. But at the same time, there has been a backdrop of rapid population growth and a rising prevalence of chronic diseases and their risk factors. So this is a main challenge that keep to be addressed. So now we will move into the transformation occurred in medical education. So the first university or higher education institute was opened in UAE in 1976, which was United Arab Emirates University, and the first medical school was the College of Medicine and Health Sciences in the same university, opened in 1984. Now, nowadays statistics show that there are 63 higher education institutes, from which 7 medical schools exist, and 9 pharmacy colleges, and many other health sciences colleges. Regarding pharmacogenomic education, actually, this is a snapshot from the website of the first pharmacy school in the country, which is Dubai Pharmacy College for Girls. And we can see here that pharmacogenomics as a course was introduced in 2007. More recent data in a paper published in 2019 showed that more courses of pharmacogenomics have been included and replaced the traditional courses in pharmacy colleges in the country. Moving now into medical research transformation. Definitely, along with all these advances in health and education sectors, there have been distinctive growth also in research. During the last years, between 2014 and 2018, medical research has witnessed a growth rate of approximately 160%. At the same period, the medical projects conducted in the country, research projects, increased from almost 700 into 1,700 projects. In the same analysis, the research projects over the last 5 years in 2018 were reported to reach more than 5,900 research projects. Most of these projects were focusing on common diseases such as diabetes, obesity, cardiovascular diseases, and cancer. Here I will briefly demonstrate the progress in pharmacogenomic research in the UAE. To the best of our knowledge, the first research conducted in the field of pharmacogenetics in UAE dates back to 1996, and it was about G6PD. In their work, Bayoumi and colleagues test the G6PD enzyme activity in healthy Emirati children, and they determined the genotypes in those found to be G6PD deficient. Soon, another study considering the acetylation status of healthy Emiratis was conducted. Woolhouse and co-workers demonstrated the high percentage of slow acetylators in Emiratis and detected two novel alleles in a study published in 1997. A quite long gap existed before the next pharmacogenetic-related paper was published. In 2011, Kamsiya and co-workers reported the results of genotyping CYP2D6 and reported 4 novel variants. Later on, in 2017, 2 pharmacogenetic studies from the UAE appeared, one related to NAT2 and the other was studying CYP1A2. Both studies included phenotyping and genotyping. Our group has studied VQRC1 variants and the correlation between the variants in this gene and warfarin dose in a group of patients using warfarin. In this study, we found that 2 VQRC1 variants, namely RS992321 and RS617 42245, and patient's age, of course, explained 50% of warfarin dose variability in the tested group. Despite their established effect on warfarin dose, a model based on the 2 VQRC variables and age was remarkably a strong dose predictor in our population. In the same study, haplotype analysis of VQRC1 variants based on the star system allele, which has been adopted from Caucasian studies or studies in Caucasian populations, didn't give a significant association with warfarin dose. In contrast, the haplotypes built from the population-specific variants was significantly a good predictor of warfarin dose. So herein the importance of population studies and the advantages in considering rare and unique variants was illustrated. All these studies actually sparked an interest from some of the main governmental hospitals to integrate pharmacogenomic information, especially for chemotherapeutic agents, specifically TPMT testing for pediatric ALL. Also, the UAE health authorities updated their policy for reporting adverse drug reactions in the UAE, and they added the requirement of an expert pharmacogenomic recommendation within the first 24 hours of each adverse drug reaction report. So following this tour in pharmacogenomic research up to date in the UAE, let's take a look on the challenges. And actually we can see challenges at the level of research and at the level of implementation. So starting with the research level, as I have demonstrated, in comparison to other populations, pharmacogenomic information originating from UAE is scarce, and most of the applied studies were observational studies that focused on frequencies rather than examining associations. In general, very few pharmacogenomic studies have been ever applied in West Asia, specifically in the Arabian populations or the Arabian Peninsula and other Arab countries in the Mediterranean east and south coasts. Indeed, the underrepresentation of Arabs in pharmacogenomic data is actually proportional to the very scarce genomic data originating from this region. And in a Nature paper titled "Genomics is Failing on Diversity," it was found that approximately only 0.08% of the genomic data available in public domains is originating from Arabic or Arab populations. Here I have adapted this figure from the paper by Lakitaki and co-workers, and in which they have demonstrated the differences among 500 pharmacogens and the different frequencies of these. But it's very clear here that and there's no data from all this region of Arab populations, because these populations are actually not included in the 1000 genome data. So we can see a significant challenge here that the Arab populations are underrepresentations, including our population, which limits the the ability to generalize the findings from genomic research. And actually, this will limit the evidence base for translating these findings into clinical care in diverse populations, such like our population. Underrepresentation actually creates inequity in the usefulness of the information, and if it keeps left unaddressed, the inherent bias in databases will continue to contribute to the lack of diversity seen in drug trials, and of course, this will reflect on uneven success rates in the precision medicine approaches. So to demonstrate this knowledge gap and to show some examples of the potential differences that can be seen in underrepresented populations, I will show now, I will demonstrate some of the results of the UAE samples from the CFARM project. So from the UAE 100 healthy participants, we extracted or detected 1,234 variants, of which 30% of these were novel. 141 of the novel variants were predicted to be damaging using in silico prediction tools. Moreover, almost 12% of the non-novel variants, or those variants that were found in public databases, were present in our population in higher rates than the rates reported in PNOMAD. So they were rare in other populations but are common in our population. This table illustrates the distribution of variants on different genes and gene families. And we can focus on these columns that show the distribution of variants in different that have specific annotation in the pharmacogenomics knowledge database among the level 1, 2, and 3. And we can see here that there are 99 variants with clinical annotation, from which 25 were in the highest two levels. Also, if we look at the novel variants, we can see here that there were 341 novel variants detected, from which 141 variants were detected to be damaging or predicted to be damaging by in silico predictions. So, as expected, unpresented population will exhibit rare variants and allele frequencies that are distinct from globally available genomic data. And such studies just highlight these deficiencies. We also revised the PharmCat reports, which were generated from the CFARM project's data results for our sample, and found that 93% of the studied groups, means 93 out of the 100 individual tested, would receive a dosing guideline based on their genotypes. And these reported recommendations would affect 34 drugs used for several indications. So in this table, we can see here the different drugs that have been affected, like clopidogrel. 29 individuals would receive an indication or a guideline, a dosing guideline, or would have to avoid clopidogrel due to their genotype, and similarly simvastatin 34, and so on. So these are the drugs that have been affected, but notably the highest frequencies of the detected actionable variations were annotated with cardiovascular drugs. And as I have mentioned earlier, cardiovascular diseases are among the highest rates in UAE compared to the other countries or in the world. So pharmacogenomic testing, and also we can add that pharmacogenomic testing cost effectiveness is proved for some of the cardiovascular drugs like warfarin and clopidogrel from other communities, which promotes these drugs as good candidates or suitable candidates for future studies in our community. Examine the opportunities of pharmacogenomic research in UAE. Actually, in February 2020, The UAE Ministry of Education has announced the selection of 4 research programs to receive its Collaborative Research Program grant, who will each receive up to 7.5 million dirhams, which is around $2 million, over a 3-year period. The first of these 4 selected researchers was individualizing cardiovascular disease treatment modalities in the UAE using a genomic-based approach, or the Emirati Heart Project, led by Professor Bassam Ali, and in collaboration with international entities and distinguished pharmacogenomic researchers. So we believe that this is a great opportunity that is available now for pharmacogenomic research and implementation. Actually, this project will be the first initiative to implement a panel-based preemptive pharmacogenomic strategy into routine clinical practice across the UAE and, to the best of our knowledge, in the whole region. So it will be the first pharmacogenomic implementation study applied on Arab population. As we mentioned the implementation, let's take a look at a short summary of the potential challenges of pharmacogenomic implementation in UAE. I found this comprehensive graph presented by Sirisna and Desanaki to list the main challenges of pharmacogenomic implementation in developing countries. While UAE cannot be considered as a low-income country, however, there are some unsimilarities and perhaps less challenges for pharmacogenomic implementation in UAE. But unfortunately, there are still some challenges there, and they are common with other developing countries. So we for sure suffer from the lack of bioinformatic tools and expertise, and from a low number of trained data scientists. Also, lack of data sharing, lack of data standardization, and also we may suffer from difficulties in ethical issues, especially the low community awareness and the conservative nature of UAE community. But also we have to consider that we don't suffer from a lack of resources. And in the last few years, genomic research and precision medicine have been already listed among the priorities of the UAE governmental fundings. So in the same review, the authors listed the suggested measures to solve the previous challenges, and here we have already passed of some of these steps, like the governmental acceptance of supporting pharmacogenomic implementation. We don't need to convince them, they are already accepting the importance or the priority of this research. And the funding is available through, though there's still need more, an increased need for more genomic education, especially for clinicians and patients. We also definitely need better measures for the ethical issues and for designing laws and regulations. Nevertheless, more data scientists are needed, and collaborations are mandatory for the success of all the measures that have been taken. Finally, of course, we need to work on the public trust and confidence in pharmacogenomics, and because it is immensely needed to ease all the future plans. So to wrap up, my take-home message for today for this presentation: challenges hampering pharmacogenomic research in UAE are starting to be controlled. Challenges are close to those faced in developing countries, though resources availability in UAE can ease them. We believe that pharmacogenomics and genomic medicine are witnessing a momentum now. Collaborations should support the equal involvement of all populations for achieving equal gains. So finally, I would like to end my talk by a quote from the WHO report entitled "The Ethical, Legal and Social Implications of Pharmacogenomics in Developing Countries," in which they said, "Finally, developing countries are not only potentially huge drug markets for drug therapeutics, but are also depositories for important human genetic diversity. So genotyping studies of these populations from around the world will become valuable in that understanding this diversity, which will better define populations and that will benefit more from a particular drug than other population, and will allow the detection of side effects and might not be encountered in populations that are mainly Caucasian. Finally, I would like to express my gratitude for the collaborators from the CFARM committee and for the United Arab Emirates University for its generous funding for pharmacogenomic research, and of course for my supervisor, Professor Bassam Ali, Professor George Patrinos for his continuous support and networking, and I also would like to thank all my lab members and colleagues. And thank you for listening. Have a nice day.
Thank you very much, Dr. Zena Al-Mahayari, for your wonderful sharing as well as that impressive take-home message as well. Well, we have a couple of questions for you to answer here. Let's get started with a big picture of the current status of PTX-guided treatment or pharmacogenomic guided treatment in both public and private hospitals in UAE, please.
So the current, you're asking about the current status. So the current status, it's the implementation is just limited by the pharmacogenomics in cancer, and specifically, as I've mentioned in my talk, TPNT, and recently NUDT 15 has been also incorporated. So these are, up to my knowledge, the only pharmacogenetic tests that are ordered in governmental hospitals. They are also available in private hospitals, but they are also outsourced. So these are, up to my knowledge, the implemented pharmacogenetic tests right now in the United Arab Emirates.
Thank you very much. The second question is about the significance of drug gene pairs that require genotyping among the ethnic UAE population before initiating a pharmacotherapy.
Yeah, we believe that we have to start from which diseases are more like forming a burden on the healthcare. So we believe that cardiovascular diseases are the main issue here. So, and we are, that's why we have started this project of cardiovascular pharmacogenetics, and we believe that it has a great potential for it to start as a project and then to complete as something, a standard care in the country. So cardiovascular drugs, I hope, and I think, and mainly clopidogrel maybe and warfarin.
Thank you. The last question is quite important because it's talking about the diversity that we have the population of UAE. So it is to ask that about the appropriateness to include the pharmacogenomics in the UAE public health without considering the acceptance of the ethnic UAE population. That's the question.
Of course, the acceptance is there, and they need maybe more than the acceptance. It needs maybe the health insurance coverage, because the acceptance is everyone is. We are, up to my knowledge, as I have met more than 300 patients during my project and sample collections, and they were all willing to, as long as we have passed all the ethical applications and we have done all the required steps to contact these patients, they were all, so there's acceptance in the public health, and there's a belief that whatever gets through the revisions, it will, the authorities refuse, it will be on the benefit of the population health. So we guess it's there, and it's just need time and need more enforcing more educational projects to make this happen.
Thank you very much, Dr. Zaina Al-Mayari from United Arab Emirates University. We've learned a lot from you. Thank you for your sharing. I believe that the most explore with each other, among this beautiful region and the world, we can create a better society with better health and from the usage of life science